So hi everyone, welcome to our webinar on achieving the gold standard of care, transforming pregnancy-related Medicaid coverage to be more holistic and patient-centered. My name is Mackenzie Marshall, and I'm the Manager of Government Relations at Families USA. I'm also the project lead of our maternal and child health team. Over the next hour, we'll reflect on the state of maternal health care by reviewing our recent maternal health publication, What's Next in Maternal Health, Transforming Medicaid to Combat the Maternal Health Crisis. It can be found on our website, and we will also follow up with a link to the paper after the webinar completes. And we will engage with experts on the importance of improving access to Medicaid pregnancy coverage by expanding covered benefits and ensuring better integration of the non-clinical community-based workforce, specifically doulas. We at the team at Families are so excited that you're joining us today. We know this is going to be a really meaningful discussion. And if you go to the next slide, please. In case you're not familiar with us, we're a leading national voice for healthcare consumers, and we're dedicated to the achievement of high quality, affordable healthcare and improved health for all. Next slide, please. Before we begin, we only have an hour and a lot of ground to cover. So to give our panel uninterrupted time to have a free-flowing conversation, we will not have an open Q&A session at the end of the webinar. Instead, as questions come up, please feel free to add them to the Q&A box. Our team at Families will be monitoring the box, and if appropriate, we'll send the questions to our moderator. If any tech concerns come up during this call, we will have Families USA staff on the front end acting as attendees. They will alert us if anything is amiss, but if you have any concerns personally, please feel free to reach out to Nate Keller. His information is on the screen. We will be recording this webinar and we'll follow up to share the webinar, and like I mentioned, the paper as well. The recording is also going to be posted on our website under the Health Justice Now webinar series. Next slide, please. A quick agenda for today. We'll begin with a 10-minute overview of our recent maternal health publication. That will be followed by a 40-minute discussion with our panelists that I'll introduce momentarily. And finally, we'll close out our conversation with a few reminders. Next slide, please. We're lucky to be joined by an amazing group of panelists and speakers today. I'll start with Krista, who is a senior policy analyst at Families USA. She leads our Medicaid expansion work, and she will give us a debrief on our recent paper. Alicia Camaliche will be our moderator today for the panel. She's a policy analyst at Families USA and serves on the maternal and child health team. For the panel itself, we have Emily Barney, who serves Families as a trauma-informed birth, postpartum, and death doula in the Reno Tahoe area. She's a co-founder and executive director of the Doula Co-op of Nevada. Sarah Hoden-Krinsky is the Deputy Director of Perinatal and Maternal Health Policy for Mass Health. She's also a certified birth doula and previously worked as the Advocacy Director of Dona International. She has a master's in public health from the Harvard T.H. Chan School of Public Health. And then finally, we have Linda Streitfeld, who is the project lead for the Transforming Maternal Health model within the Center for Medicare and Medicaid Innovation, CMMI. She is a master's in public health from the George Washington University. So thank you all so much for joining us today. I'm going to turn it over to my colleague, Krista, to talk about the paper.
Thank you so much, Kenzie. So why are we talking about Medicaid and maternal health? The US is the only industrialized nation where the maternal death rate is rising, and Indigenous and Black women are 2 to 3 times greater risk of death than white women. And Medicaid's role as the largest payer of reproductive health care in the country, covering 42% of births and an even greater share in Black, Indigenous, Alaska Native communities and those living in rural areas, Medicaid is uniquely positioned to impact pregnancy and well-being of pregnant and postpartum people. Our vision for this project is to imagine that Medicaid can become the best of coverage for maternal care in the US. Our approach was to reimagine coverage pathways, accessibility, and delivery of maternal health care that is holistic, patient-centered, and equally accessible throughout the care continuum. Although our paper is not comprehensive of all the actionable opportunities for federal, state, and local actors to improve Medicaid coverage for perinatal people, we tried to be as inclusive as possible by identifying coverage gaps, benefit variations across states, and ways community provider networks and community-based organizations can better integrate into a delivery system to provide responsive care. The nation's current system of publicly supported coverage options for pregnant and postpartum individuals is a complex patchwork and sometimes inconsistent. Captured nicely in this figure of coverage from preconception to postpartum across Medicaid, Child Health Insurance Plan, or CHIP, and marketplace coverage pathways. States are mandated to provide coverage for pregnant women with an income threshold of at least 138% of the federal poverty level, or FPL, under Medicaid, encompassing broadly defined services in prenatal care, labor, delivery, and a minimum of 60 days of postpartum care. Additionally, pregnant women not eligible for Medicaid can receive coverage through CHIP. States have the flexibility to enhance this coverage by setting eligibility thresholds above federal guidelines, offering comprehensive benefit packages, and extending coverage to lawfully residing immigrants within both Medicaid and CHIP. And despite many states surpassing minimum coverage standards, significant gaps persist. Hundreds of thousands of women face obstacles accessing coverage before pregnancy, experiencing delays in critical times due to eligibility processing, or federal laws barring immigrants from public assistance for 5 years. Moreover, immediate coverage loss post-birth is common, particularly with CHIP unborn child, which you would see in this blue line in the figure, which lacks postpartum care and terminates after childbirth. And to illustrate the impact of postpartum coverage, continuity, or even slight changes in income affecting eligibility, let's consider a scenario where a new mother transitions between coverage types after giving birth. Without continuous coverage, she may face what's known as churning between plans, which can be a headache to navigate during an already challenging time. And with postpartum extension, uninsured new mothers gain a crucial new option for continuous coverage that can seamlessly remain enrolled in the same coverage type during pregnancy and delivery without disruptions or changes. Having coverage before, during, and after pregnancy improves both maternal and infant health outcomes throughout their lives. And Medicaid expansion is an integral step towards closing the coverage gap or falling off a coverage cliff. For example, in Wyoming, one of 10 states that have currently chosen not to expand Medicaid, has one of the highest uninsured rates for women of childbearing age. And this woman in this figure would be ineligible despite making notably less than the state median income. These gaps and barriers contribute to disparities in maternal health outcomes. And in Wyoming, maternal mortality increased by 41% since 2018. Another challenge across states is not just who is covered, but what is covered. Most states provide comprehensive health coverage, including prenatal care, labor, delivery, and other medically necessary services. However, each state Medicaid program covers different perinatal support services and education. And among these supports, some states do not cover critical services like doulas, lactation consultant home visits, dental coverage, despite evidence to support improved health outcomes and cost savings for states. Administrative hurdles, such as prior authorizations, prescription requirements for over-the-counter products, stringent medical necessity requirements, create significant barriers to accessing care. Again, in Wyoming, for example, it requires prescriptions to cover prenatal vitamins. And in order to improve mental health outcomes, there's a need for standardized and expanded coverage that includes these critical services across all states. However, progress is being made both in coverage and in benefits. And we want to continue this momentum by one, broadening access to Medicaid coverage. And there are many ways to do this, and I'll highlight one. In 2021, the American Rescue Plan Act created Medicaid and CHIP state plan option to extend coverage from 60-day postpartum to 12 months after the end of pregnancy, with federal matching funds to incentivize longer coverage in response to the alarming rates of preventable deaths among new mothers a year after birth. And we applaud the federal government in their support of states and the very successful uptake of extended coverage across the country. And I'm happy to report, as of 3 weeks ago, 46 states, including Nevada, US Virgin Islands, DC, have implemented 12 months postpartum coverage, mostly through state plan amendments and a few through 1115 waivers, which we'll talk about briefly. And the remaining states have already made significant progress towards extending coverage, demonstrating a growing commitment to maternal health across the nation. And we want to continue the momentum of providing robust delivery. Medicaid 1115 waivers, which waive federal provisions to allow states to innovate Medicaid delivery and payment, have been used to expand benefits to include and cover doula care. Doulas are non-clinical providers. They provide emotional, physical, educational support that complements medical care. Some doulas provide a full spectrum of services that cover the entire perinatal period, while others may focus on labor and delivery or postpartum care. And when doulas are present and a part of a client's journey, data has shown to improve outcomes for perinatal people. And currently, doula services are covered by Medicaid in 12 states. And while states have swiftly adopted these benefits in Medicaid, new programs face challenges such as low and delayed reimbursements, administrative burdens, insufficient support for community-based doula models, and these obstacles are hindering doulas from serving their communities effectively. However, CMS has introduced a new model requiring coverage of doula services in this care model called TEMA, Transforming Maternal Health. And under TEMA, 15 states can apply to enhance access, quality, and equity for pregnant individuals enrolled in Medicaid and CHIP. And this whole person care approach integrates various maternal health resources and services. And by breaking down silos, TEMA fosters collaboration among the providers, hospitals, birth centers, community-based organizations, managed care organizations. And additionally, the model emphasizes the coverage of doula services through Medicaid authorities, providing payment guidance, training, and support to ensure standardized and community-integrated care. And this model addresses both the medical and non-medical needs, recognizing the vital role of CBOs and community providers in reducing disparities. And we commend CMS for prioritizing the involvement of community-based providers and organizations in delivering dignified, responsive, and respectful maternal care. So in summary, with the growing momentum and expanding coverage for 12 months postpartum doula services and recognizing the pivotal role of community-based organizations in delivering holistic care, we are committed to continuing these efforts, including broadening the eligibility, streamlining enrollment, enhancing benefits and services for comprehensive care, and forging meaningful partnerships with community organizations. We would love to stay engaged and continue this conversation, so please join us in our movement towards excellence in Medicaid coverage for all perinatal people. And with that, let's begin one of hopefully many more conversations. I will now hand it over to my colleague, Alicia, who will begin our panel discussion.
Hi, everybody. My name is Alicia Camaliche. As Mackenzie said, I'm a policy analyst here at Families USA. I'm going to start off by welcoming Emily, Sarah, and Linda to the panel discussion portion of this webinar. We're going to build off of Krista's really incredible presentation and engage our expert panelists in a discussion on the importance of improving access to holistic perinatal healthcare. And even more specifically, what efforts have occurred to expand access to doula care and community-based care broadly on the federal, state, and local level. To kind of help set the stage for this conversation, I want to begin by defining a doula for those in the audience who may not understand the role of a doula or the importance of access to doula services. Doulas are non-clinical patient advocates who provide physical, emotional, and educational support throughout pregnancy, labor and delivery, and into the postpartum period. Patients who utilize doulas are 2 times less likely to experience birth complications and 4 times less likely to have a low birth weight baby, and are more likely to be satisfied with their care. So despite this ample evidence, and there's even more evidence that doulas are integral to improving the health of pregnant people and babies, as of 2023, only 11 state plans include doula services within their Medicaid pregnancy benefit. Adoption of a doula benefit is a prime example of a major step state Medicaid agencies can take in supporting the health of pregnant people. And the good news is the number of states with these benefits is growing. But as more states work to cover doula and community-based services, it's become increasingly apparent that there are a lot of transferable lessons that we can learn across the states. Every state Medicaid agency has taken a different approach to the doula involvement in benefit design, reimbursement rates, training pathways, registration, oversight, and all these other components that work together to go into making a benefit. On top of state efforts, CMMI is working to support states in supporting doula access through the new TEMA model, transforming maternal health that Krista mentioned. And so with that kind of background, let's move into our panel discussion. And we're going to start off with the federal level. on what CMS is doing to improve the delivery of maternal health and better integrate doula services. And then we'll talk a little bit more about what actions and challenges are occurring on the state level. So let's jump right in. Linda, I'm going to start with you. Can you tell us about the goals of the Transforming Maternal Health Model, commonly known as TMA, and how it contributes to the goal of holistic maternal health care?
Well, thank you. Thank you for that introduction and for the great summary that you all did earlier of the model. We are very excited about introducing this model. We have not yet released the notice of funding opportunity, so no states have yet had an opportunity to apply to the model, but it will be a 10-year model with the goals of reducing disparities in access, treatment, and outcomes for mothers and their newborns, while also reducing overall Medicaid program expenditures. If that sounds like a big lift, we agree, but the model will provide financial and technical resources to up to 15 state Medicaid agencies to help them do some important things that evidence suggests can really move the needle. So we want to broaden the maternal health workforce, and that includes broadening access to doulas, improve the quality of care delivered across the perinatal continuum, and establish reliable referral pathways to and from community-based organizations, especially to address those health-related social needs, and overall to promote care that is person-specific, culturally sensitive, and rooted in active listening and development of trust.
That's so great. Thank you, Linda, for that recap. I really love the balance of both investing in quality of care and outcomes, as well as reducing expenditures and costs. And I think community-based organizations are really integral to achieving both of those things. So I'm interested to hear how the TMA model will support state Medicaid agencies in developing this kind of whole person approach to pregnancy, childbirth, and postpartum care, specifically encouraging integration and collaboration between state Medicaid agencies, managed care, and community-based organizations who we know are delivering really important services that both address SDOHs, reduce overall expenditures, and improve outcomes. Can you speak to that a little bit?
Yes, I will do my best. So first of all, for each of the states that participates, we're going to be offering $17 million across the 10-year model lifespan. In addition to those dollars, which by the way will be kind of front-loaded toward the beginning of the model because they'll be able to be used by states to help set up some of the infrastructure pieces that are going to be important. We're also going to be offering very intensive and tailored technical assistance to states. So we understand that states are at different starting points for a lot of these elements that we've incorporated into the model. And so our technical assistance is going to need to be very specific to address unique circumstances within each state. And in addition to that one-on-one TA, we're also going to be offering opportunities for peer-to-peer engagement between states and some group learning. The Medicaid agencies will be required to partner with all of the managed care plans within the test region in their state. And those plans are going to be key to supporting the changes in care delivery and operating the payment model. And then engagement with community-based organizations, also critical. Some of the funding that we will be providing to the Medicaid agencies in year 3 of the model is going to be funneled to those managed care organizations and their providers to help support that engagement with the community-based organizations. And states that choose to do so can also get support for regional partnerships in rural areas, community hospitals, and also partnerships between rural entities and then larger hospitals and health systems to try to manage the risk for rural births. So I hope that's helpful.
No, that was very, very helpful. It's really great to hear about the kind of emphasis and focus on integrating community-based organizations and also that technical assistance piece, which I think is maybe not talked about enough when it comes to the difficulty state Medicaid agencies have or states have when developing new benefits or improving on delivery of care. And I also appreciate the emphasis on rural health, which we'll talk about a little bit more later on. So thank you for that. Even among participants on this call, Nevada and Massachusetts have had very different experiences moving through the process of implementing a Medicaid doula benefit. Sarah, I'm going to kind of move over to you. Massachusetts is unique in its approach to adopting a Medicaid doula benefit in that I know the state took up the effort without legislation or without a budget that mandated this coverage. How did the state's decision to move forward with a doula benefit in this way impact the development and implementation process? And how did Mass Health kind of ensure that the needs and voices of doulas were included in that process?
Sure. Thank you for the question and thanks for having me. Just a quick bit of background. So Mass Health, which is Massachusetts Medicaid and CHIP program, we started covering doulas about 6 months ago, December 8th, 2023. We cover doula services for members during pregnancy, delivery, and then through the 12-month postpartum period. And that's inclusive of all pregnancy outcomes, including abortion, miscarriage, stillbirth, live birth. And also Massachusetts does cover undocumented pregnant folks at state cost. So those folks are also eligible for the doula services benefit as well. So like you mentioned, Massachusetts may be in the minority of states in that there wasn't a bill that passed that said, Medicaid agency, you must cover doulas now. However, and this was in full transparency, this was before my time at Mass Health. But at the time, I think just based on the robust literature on the impact of doulas, not only on outcomes like C-sections and preterm births and all of that, but also on patients' experience, and particularly for Black and Brown families. Mass Health kind of realized like this is something that we want to do. We think it's the right thing to do, and we don't want to wait for potential legislation to pass. We're going to move forward with it. So before the doula coverage went live about 6 months ago, there were years of policy development and stakeholder engagement that went into that process. So for several years now, Mass Health has been engaging with stakeholders, including doulas themselves, through various meetings, public listening sessions. We put out a couple of different requests for information to gather feedback from doulas and other stakeholders as well about sort of to help us inform the policy development. There's been a little bit of helpful literature that's been published specifically on the needs of Massachusetts doulas. So we really leaned on that literature as well. And we also partner very closely with our colleagues at the Department of Public Health in Massachusetts, who are also doing a lot of work around supporting the doula workforce in Massachusetts more broadly. So definitely engaging with doulas has been really key. And I just want to highlight one other piece, which is that we're super excited about covering doulas. This has been something that has been in the works for years. Doulas are absolutely critical to improving health outcomes, but we also really recognize that doulas alone cannot fix all of the systemic issues that cause poor maternal health outcomes, and particularly disparities and inequities. And so we really view the doula coverage as part of a multi-pronged approach. Critical, but not able, doulas should not hold the maternal health crisis on their shoulders by themselves. So just wanted to emphasize that.
Yeah, I mean, absolutely. I think that's totally true. And, we'd never want to underestimate the importance of doulas, and also recognize that this problem is much larger than access to doulas alone, and than a problem that doulas and the incredible services they provide can fix. Thank you for that, Sarah. I think that's extremely helpful context. And I completely agree. I think whenever creating any type of new benefit, especially a benefit that involves the community-based workforce, integrating that workforce, understanding their needs, understanding their level of ability to move through a Medicaid system, I think including their voice in that process is so important. And it's great to hear that Mass Health understood that importance in the design of this benefit. Emily and Linda, can you speak to how Nevada's SMA integrated the voices of doulas during the benefit development process, or how CMMI has encouraged the inclusion of voices of community-based workers through the TEMA model? Emily, we can start with you and then move over to you, Linda.
Yeah, happy to. Thank you also for having me. Excited to keep the conversation going. The integration of doulas at the beginning of the doula benefit design was before my time as well. And so I was a doula in the community of Nevada. I had just moved here and was getting connected to the doula community, but it was still rather held up in small groups. There was not a collective effort. There wasn't a community-based organization that represented the voices of all doulas in the state. Nevada is also unique in that way. Our state is just demographically very different regionally. Communities are highly rural, even though most of our population lives in 3 urban counties. So there were a few doulas and stakeholders kind of in the public health realm who were really pushing for our legislation. And we did go through legislation, and we were relatively early in the process of the other states in the nation taking this on. And so we started off with an incredibly low reimbursement rate. And there was very little incentive for doulas to join the benefit after it had initially passed. And so in order to get us onto the legislative deck and to really be seen and to let this legislation pass, doulas were somewhat a part of just presenting the knowledge and presenting it at the legislative testimony. But after that, there was not a lot of follow-up from those same stakeholders. And so the Doula Co-op of Nevada was kind of born out of this need for, well, we need to integrate and implement this benefit now, and we need all the voices to be represented.
So that is really helpful to hear, because one of the requirements of our model is that states convene what we are calling a doula support council, but it sounds like what you all have done. Because of federal restrictions, we can't control too closely exactly what those councils look like or who's on them or exactly what their purpose is. But we think that states that apply and are accepted into the model are going to understand that the idea of this is to get doulas themselves involved and make sure that they do have a voice in thinking about not only payment rates, but all of the obstacles that you mentioned earlier. How do you register as a Medicaid provider, and how do you apply for payment, and all of those things. So we're hopeful that those councils are going to be a really important piece of making a doula services benefit as useful as possible.
Yeah, I appreciate you saying that. And I want to just add one more piece that, like, we have a doula advisory committee for our state certification. And that was like the only organized effort of the state Medicaid agency to bring doulas together to have this conversation. And so people applied and I applied. That's how I sort of entered this space, was through this advisory committee. And what we were able to do, though, was not really policy related or what was interacting with the state agency or interacting with federal agencies or the MCOs. We were just advising on the certification. How do we build the certification at the state level, which was helpful because we obviously needed doula involvement in that process. But there's been so many other steps that we could be critical in being thought partners in. And so we're doing that a little bit more on the back end, where Team Up, the model really does sound like it is addressing it on the front end, which is much appreciated on our side.
Yeah, no, we do want to do that. And so, and we will be interested in seeing what we can learn from your process, because, that'll help us as we work with states.
Absolutely. Emily, what you said about the process that occurred in Nevada, I think is a perfect example of how these problems can potentially be avoided with that upfront inclusion and integration of community-based organization, the voice of community-based organizations and doulas in particular. I appreciate especially what you said in terms of reimbursement rates. I think we've seen in other states like Oregon, if the reimbursement level is too low, doulas won't participate. They're not able to participate because payments are just not adequate enough to cover the time and resources it takes to provide these important services. To do their work, of course, doulas and the community-based workforce need adequate compensation. So I'm wondering if we could talk a little bit more about that process that the Doula Co-op of Nevada took a hold of and kind of helped guide. Can you tell us more about how your work at the co-op kind of adapted to meet the needs of advocacy within the development of this benefit and implementation of this benefit, and the needs of the Nevada communities to ensure the best possible outcomes for doulas who are working to be reimbursed by Medicaid?
Yeah. I will, like Linda said, I'll do my best. I could talk for 40 minutes on that. We first came together as an organization to just address that Medicaid was happening in our state, and doulas who wanted to enroll in the process, they were all just sort of dotted around the state without any way to collect and get to know that there are other people wanting to do this. And so we just wanted to be a hub for that. And so that's really how we started. And then doulas found us and they were like, you're doing this? We want to do this. We want to collaborate. We want to network. We want to be in this. And so that's really what like built the beginnings of our community. And since then it's really expanded, and we support doulas who work with the end of life as well. And so we now have this like multi-spectrum, well, full spectrum work of doula services. But what we are trying to understand within our communities in terms of advocacy is the regions and the uniqueness of Nevada as a state. Southern Nevada is very different than Northern Nevada, and the providers who are ready and interested to address the Medicaid system may not have the same resources or may not feel as trustful of the system and entering it as well. Demographically, we have a large Spanish-speaking population, and yet most of the doula population within the workforce are white and English speaking. So we have a real gap in demographic workforce and the diversity in the workforce and being able to represent the communities. And so the doula co-op, doing what we could for that, we hired a Spanish teacher to create a doula-specific Spanish class for the doulas in our community to better serve that community. But that was a Band-Aid, because really what we need to be doing is training and building a workforce from within the communities themselves. And so that looks like scholarships. We've gotten funding to provide scholarships to increase the diversity of the workforce from within underserved communities, really understanding that there's not a one-size-fits-all fix to this. And so there has to be, different resources in Southern Nevada and rural Nevada and Northern Nevada. And so we're looking at our community sort of in this regional way, and then trying to create local hubs of support, education, and advocacy for the doulas that are in those areas, and getting them together, empowering them to learn who's in your community as doulas and support each other. Outreach has been a big part of that as well. Getting out and just sharing with people that this benefit exists. There's so many people in our state who don't even know that this is covered. So many doulas who don't know that they could be covered. And the reimbursement rate needed to be addressed before any of this could, because no one was going to enroll. But that's, a different legislative session that we went to in order to increase the reimbursement rate.
The work you all have done in Nevada is incredible. And I'm just, interested to hear, what has the impact of everything that you could just kind of ran through been on the number of doulas participating in the Medicaid program? Have you seen a huge uptake in this benefit?
I wouldn't say huge. I'd say we're like trickling in as people are learning about it. And right now our fee schedule, even though we had our legislation passed last June to increase the reimbursement rate by more than 3 times, that fee schedule is not fully reflective yet. And so when you look on the Nevada website, if you're trying to become a doula provider, it still says we're getting paid $350 for our total benefit package. And so doulas don't know that that legislation is passed. We know it as a community internally. And so with our community in terms of the doula co-op, everybody within our community knows that. And so they are enrolling in Medicaid because they know the fee schedule is changing, and they know that we have the communication from our state Medicaid agency to let us know when that's fully live, because we have been working with them. The benefit is retroactive from October 1st. And so doulas can receive this higher reimbursement rate from clients they took in October, but the process for enrollment and just frankly getting through all of the contracts with MCOs has been really challenging for doulas, business licenses, just navigating this healthcare system that was not designed for us. Like you mentioned, we're non-medical providers, and we've been mostly in the private sector. And when you're now integrating into these large health systems that are not built for you, there's not a designated point of contact within MCOs or even our state Medicaid agency. So we're having to find someone who can find someone who can find someone to get us into the place that needs to hear what we're experiencing. And we're just now making connections with our state Medicaid agencies and our Department of Healthcare Finance and Policy as well. So it's been a lot of learning in that regard.
Yeah, the work keeps going, huh? Thank you. Thanks, Emily. I think that was really helpful. And I will probably touch on a few of those points later on. For Sarah, I want to kind of jump back to you because obviously designing a benefit is so much bigger than just picking a reimbursement rate. I know many states cover doula services through their managed care organizations. That's a common choice. But in Massachusetts, you chose to adopt it as a wraparound service. Can you tell us about the differences between those two distinctions and how it impacts the process for doulas and why Mass Health made that choice?
Sure. And fair warning that this is getting into the policy weeds. So anyone on the call that's a Medicaid policy wonk, maybe your ears will perk up. So yeah, and just to reiterate that point, I think, there's so much focus nationally on doula reimbursement rates, which of course are critical, but I can't emphasize enough how many other key decisions there are in designing the way that the doula coverage will work in various states that really, I think, have a huge impact on not only how many doulas are going to enroll, but how many of them are actually going to be able to serve members and bill and get paid successfully. So I think, this is one example of one particular design choice that we made here in Massachusetts. Caveat being, I'm not sure whether this is a choice that every other state can potentially make. I know Medicaid runs very differently from state to state. Here in Massachusetts, roughly 90% of our pregnant and postpartum members are in some sort of managed care product, typically an accountable care organization, ACO, or a managed care organization, MCO. However, we chose to administer our doula benefit as what we call a wrap service. And I think maybe some other states might refer to this as a service being carved out of managed care. And essentially what that means is our state Medicaid agency is administering this benefit directly. So doulas, it's sort of a one-stop shop for doulas. Doulas will apply and enroll with Mass Health, which is our state Medicaid agency. They'll bill us directly and we'll pay them, as opposed to, I think in some other states, and it sounds like maybe this might be the way it works in Nevada currently, where doulas have to enroll potentially with the state Medicaid agency, but then also have to enroll with separate MCOs, bill each of those MCOs separately in order for the members in each of those MCOs to have access to doulas. So this was, again, a decision we made. And I think, my hypothesis is that this decision may be helping to address some of the barriers that we've seen in other states in terms of enrollment, and reducing some of the administrative complexity of what it would mean to enroll with and bill many different MCOs. And then from the member side too, I think it creates a little more simplicity and greater access for members, because no matter where you live in Massachusetts as a Mass Health member, no matter if you're in an MCO, you're not in an MCO, which one you're in, everyone has the same access to the same network of doula providers who often are willing, at least in Massachusetts, to travel quite a bit away. And then we also cover doula services through telehealth as well. So I think, that's been a really key element of the way that we designed the benefit here in Massachusetts.
Thank you, Sarah. So I definitely understand that this choice was in recognition that Medicaid reimbursement can be tricky, it can be burdensome, and trying to choose the path that was easiest for doulas and helped expand access for patients. I think the lesson learned there is even states who are going through the managed care route and covering through some type of managed care organization should still focus attention on how best to streamline that process to reduce that burden, both for providers and patients. Emily, in your experience, how can state Medicaid agencies and MCOs provide support as doulas navigate these new waters? I think we hear all the time that it's really tricky for many community-based workforce members to move into the Medicaid reimbursement system, even when a benefit is designed for them. Are there any transferable lessons learned that you think might help interested advocates in other states kind of streamline that process?
Yeah, many lessons learned. I mean, I think what Sarah just said was really important too, is that the process needed to be streamlined in order to make it so that doulas felt like they only needed to go to one place instead of I have to go here and then I have to go there and then I go here and then I finish here and then you go wrap back around. And it's really challenging, and there's time limits on things. There's one thing will time out and then now you have to start all the way back from the end. That's happened to several doulas where they almost completed their entire Medicaid application. They needed to just have some life things happen for them, and then it reset and they had to start all the way back at the beginning. So I think streamlining the enrollment and the credentialing process is crucial. We've seen that. Also including beginning the reimbursement rate being accurate, and also building in the services that make sense for what we are doing. And so like doulas they need to be able to have access to their clients and to have, prior authorizations and aspects of this where we are being like held up at each point before we can just administer the care that we need. That also takes away from what we can do. So in terms of the credentialing and enrollment part, simplified contracts, and your paper really, I was reading the paper and there was a lot of wonderful recommendations in there that I would agree with. Simplified contracts for doulas that do not require certain aspects of medical groups, and different numbers and various things that we just don't have any hand in because we're non-clinical. So those things would be huge. Having a point of contact. This was also a recommendation in the paper, was having a point of contact within each health plan and within the state Medicaid agency. And then if there are community-based organizations, and if there's not, then create the opportunity for a listening session, for a community conversation to happen so that doulas are aware, hey, we want to work with you and we are interested in hearing about your perspective and we want to create a policy that is holistic for your needs as a community and a provider, and then the families that you serve, because we're the ones who work with these families and know their access levels and what they need. Just the literacy as well of this whole journey. This is learning a new language for doulas, and we're meant to be doing the credentialing, contracting, and enrollment, as well as providing the service, as well as seeking the referrals, as well as doing our individual claims and managing all of our billing, which in Nevada is not happening. Doulas are not being paid because the back end system on most of the MCOs is completely different. And so there's also not a uniform way in which doulas bill across the MCOs and the state agency. And so the state agency has one set of codes. The Medicaid managed care organizations have one of them has said that they use the same codes as the state, but in practice, that isn't showing to be quite true for doulas. And then the other MCOs have different systems as well, and claims are getting denied from one MCO, and then the other MCO, they're being approved with the same reasoning, or they're being denied for one reason and another. And so there's just no uniformity in that, and there's a lack of awareness and education around what does a doula do. And so the training and education of doulas as providers for health plans, for case managers, people who are working with and can refer people to doulas, is huge. Making sure that those who are working in the populations of pregnant people are aware that this benefit exists, being able to explain it accurately, and then being able to refer to the providers in their area, and make sure that those connections are integrated. I mean, really, it's like the topic of this whole thing is just integrating us with giving us the chance to do the work that we're meant to do while recognizing that we're unique and that we do have certain needs that are going to be different than other providers. Having a dedicated billing and claims, not just contact, but platform, which we've been addressing here in Nevada as well, that there are some digital services and some digital companies, not necessarily all digital, but there are companies that are helping to integrate doulas into Medicaid by billing on our behalf, sort of like a clearinghouse would for medical providers. And so we've been exploring partnerships there and trying to make the MCOs aware. And we have one MCO who is doing that, which is awesome. And so doulas are going to be favoring to work with the companies and work with the health plans who are looking to work with us and bring on creative solutions for the issues that we're experiencing.
Thank you, Emily. I think that makes total sense. We hear from clinicians that work in clinical practices and have full staff to help with billing, and they still can sometimes have barriers. So acknowledging that the community-based workforce is in its own place, meeting them wherever they are and giving them the resources necessary to facilitate their process, I think is absolutely important. Linda, I'm interested to hearing from you how CMS can play a role in supporting state Medicaid programs and MCOs as they work to provide this kind of support for doulas. And then once you answer that, we'll kind of move on to a question or two from the audience.
Sure. Again, I think our doula support councils are going to be really important, but this is where that tailored technical assistance is really going to be critical, because different states are setting up their benefit in different ways, and they're in different places. And, the difference between a fee-for-service or a carved-out service and an MCO-based service is going to require different setups. So the technical assistance is really going to help states to figure all that out and help them with the analysis to make sure they get the right payment rates. The right rate is going to be different in each state, but it still has to be some kind of a living wage. And so we'll have assistance to help sort that out. I really appreciated what Emily said about streamlining enrollment, agreeing on consistent billing codes across. And these are all things that we can help with, not only from the TA, but with enabling states to talk with each other and sort of share notes about what's working and how they're thinking about doing it.
Absolutely. I absolutely. And I wrote down those points because I think that they're so great. Thank you, Linda. Moving on, knowing that we only have, I believe, 5 minutes left, I want to move to a question from an audience member. The question is, Oklahoma Medicaid includes doula services in the benefits for the pregnancy-only plan for undocumented persons. Looking for suggestions on how to make this population comfortable and confident asking for doula services. Sarah, I know Massachusetts provides coverage for undocumented persons. Emily, I'm unsure if you have experience in this, but any advice from our audience member would be really appreciated.
That's a tricky question. I would just say that I think in Massachusetts, we really rely heavily on kind of our grassroots community-based partners who are really on the ground working with undocumented folks, because let's face it, folks who are undocumented oftentimes have a lot of mistrust in state government, and for good reason sometimes. So I think, also recognizing where the state Medicaid or state government should play a role versus when we should be really leaning on folks who are on the ground in community is really key.
Yeah, I'll just note that one of the things that our model is going to require is a health equity plan. And part of that is not only ensuring that there is that care is offered in a variety of languages, but also really leveraging those local voices to assess where are the gaps in coverage and sort of develop strategies for not only building, but supporting a culturally concordant workforce. And I think that is one real primary, bottom line requirement to build trust in the community, is to have doulas that look like your community, whether it's tribal or Hispanic or African-American or whatever you need in your community. Sorry, Emily, I didn't mean to talk over you.
No, you spoke beautifully. And I would, that was honestly what I was going to say, is that cultural congruence is an incredibly important part of building a doula workforce and identifying who is in your workforce too. And this is another transferable lesson, I would say, is that who is the workforce of doulas who's currently in your state? As you're developing these benefits, where are the doulas located? What are the barriers that they experience to being a doula and staying a doula? Because that's one thing the Doula Co-op of Nevada has identified, is that the sustainability of being a doula is very low. It takes a lot to not just become one, but then stay one. And so if we have, organizations and support structures in place to maintain doulas from these different communities, then that's a hugely important part of making sure that it lasts. And for undocumented folks and people who are in positions where, like Sarah said, I would agree, there's a lot of mistrust. They're going to need to have people who look like you and to have the same lived experience as you in order to feel the complete, I wouldn't say just the benefit, but like the benefit and value of working with a doula is to feel seen and to feel confident and to feel centered in your care. And so if someone is coming in and they don't even know if they can trust their doula, because the doula could be someone who shares their status, and that influences their entire safety and livelihood structure. So that is a crucial part that I would say. So thank you for highlighting that, Linda.
Yeah, thank you all for, I think, again, we can't emphasize enough the importance of the community-based workforce in providing care that feels safe, is culturally congruent and holistic to pregnant patients. So thank you for that, for those points. I think we have another question in the chat that I maybe want to direct towards you, Linda. The question is, in states where community health workers are available for Medicaid reimbursement, would love to hear the panel's thoughts, so Linda or anyone else on the panel, on community-based doulas as a specific type of perinatal CHW. And if you know of any states thinking about exploring this type of path to expanding doula care. So my understanding is utilizing existing CHW reimbursement to expand access to doula care.
Yeah, I don't know exactly how that would work. I can tell you that we are trying to be as flexible as we can about what constitutes doula services. And if states can figure out ways to provide those services using perinatal CHWs or other community workers, we would be happy to look at that. I think Tennessee is thinking about that, and I'm not sure who else, but happy to hear from others on the panel.
We've had that pathway kind of open up, and there's been some conversations around it. In Nevada, the Doula Co-op of Nevada hasn't particularly explored that yet. But I know that there's at least one who's working with a Southern Nevada Health District, Heart and Soul Collective. They're an organization as well who's providing services, and they are exploring how to bring CHWs and doulas together, but it requires a lot of intention, I think, because a CHW has a scope of practice and a doula has a scope of practice. And when you try to combine two things into one thing because it looks really attractive, you might not get the things that you're looking for from both. So I think a CHW needs to be honored in the CHW's scope of work and how they operate in their communities. And a doula has to be acknowledged and seen in those ways too, before we start saying, well, these could be the same. Let's see if they can make a new thing. It's like, well, we can't even integrate doulas correctly yet into the system. CHWs are still a really new workforce, community-based workforce as well, that are still struggling with reimbursement rates for themselves and being able to access the services and technical support that they need. And so to try and then create a whole new thing that no one knows about, but has good intentions behind it, I certainly believe that it is a strong possibility for the future. It's similar to like home visitors. There's home visiting programs across the states that are also doing really wonderful work in being in the communities and working directly with families. And they're trying to do the same thing, is like, can we get a doula training? And I think that's really what we've come across, is that like CHWs can be trained as doulas and they can have that knowledge and they can have that understanding, but that doesn't mean necessarily that they become their own provider type. They can just wear one hat or wear the other and then have two perspectives.
Thank you so much, Emily and Linda, for those incredible answers. We have covered a ton of ground in not that much time, so I appreciate you all for engaging in such a really productive conversation. When it comes to recent efforts by CMS and states to make maternal health more holistic, this has been such a great panel. We've covered experiences with reimbursement, navigating Medicaid, importance of integrating doulas into care teams, providing doula resources. This has been so productive, and so thank you so much. We're going to end here and turn it over to Kenzie for our closeout. But again, Sarah, Emily, Linda, thank you for an incredible conversation. We are so lucky to have you here today.
My pleasure.
Thank you, Alicia. And thank you so much to our speakers and panelists who joined us today. That was a really insightful conversation and highlights the need for all of us to create more spaces for the transfer of knowledge and lessons learned between states and federal advocates and policymakers. We hope that you'll join us in continuing to build off of this conversation through your own work and through sort of broadly Medicaid advocacy. So thank you all who joined us over Zoom and for sending in questions to the Q&A function. I apologize that we weren't able to get to them all, but this was a great turnout. I do want to flag that that during our paper presentation, our eligibility diagram listed that 400% of the federal poverty level was an eligibility limit in the ACA marketplace coverage. There are now more flexibilities that include thresholds above 400%. So thank you, the audience member who pointed that out. And just a quick reminder, I'm going to follow up with a recording and a link to the paper. I'll also send a few more resources from some of our speakers. If you do have any questions about any of the policy that was covered during this discussion or in the paper, please don't hesitate to reach out to us and follow up via email. And please continue to check our website and our resource roundups for any more information about upcoming webinars and papers that are coming out of Families USA. I do also want to quickly make a plug for this year's Families USA Academy Fellowship. The application is now open to all healthcare providers, including nurses, oral health providers, community health workers, and any other providers who work closely with communities experiencing health professional shortages and other systemic barriers to care. The fellowship includes monthly training sessions and networking opportunities with leading voices in healthcare advocacy, as well as participation in Families USA's annual Health Action Conference. We'll follow up with a link to the application when I share out the webinar recording and paper. So with that, let's close out. Thank you all so much. I hope you have a great day, and let's keep up the good fight.
Thank you, Kenzie. Thanks, everyone.
Thank you so much.